Bro, why is Primobolan so expensive? Well, it's probably because it's the best injectable anabolic androgenic steroid you can take on top of your testosterone base when you take everything into consideration. Discounting for hair loss, obviously. But what's the best weekly dose of Primobolan then, you might ask? Let's find out after the disclaimer. Vigorous Steve here. Join me as we analyze the medical insert of Bayer Rehabilitation, go through all the clinical trials and human scientific evidence performed on Methenolone Acetate and Enanthate to figure out what the best dose of Primobolan actually is. Spoiler alert, it's anywhere between 25 milligrams per day up to 1200 milligrams per week. So let's get started with the medical insert. A huge, big shout out and thank you to Ali and Alpar who helped me translate the Bayer Rehabilitation insert back in 2021 from Turkish to English. They sent me the translation by email a long time ago. So my sincere apologies that I've been sitting on this translation for such a long time, but I haven't really found a proper video to put the translation in. You can find the link to my Dropbox account where the translation can be downloaded, again, down below in the description section. Let it scroll a little bit longer so you can get an indication of how big the medical insert of Bayer Rehabilitation actually is. At certain parts, the medical insert is a little bit hard to understand, so I summarized all of the instructions revolving around particular medical treatments involving Methenolone Acetate in an easy to understand list, which is on the screen right now. So let's go over the treatments. In case of sarcopenia and muscle wasting diseases, Methenolone Acetate is prescribed in the following sense: 200 milligrams intramuscular as a starting dose, then 100 milligrams intramuscularly weekly for 2 to 4 weeks in duration, or 100 milligrams intramuscularly weekly for 3 to 4 weeks. And these treatments can be halted between 2 to 4 weeks if required and then restarted. And in cases of weight gain in underweight women, the starting dose is 200 milligrams intramuscularly, followed by 50 milligrams intramuscularly every 2 to 3 weeks. So this is a significantly lower dose at, let's say, 17 milligrams to 25 milligrams weekly. And these treatments can be halted for 2 to 4 weeks if required and then restarted. And in cases of advanced breast or genitalia cancer in women, there's 100 milligrams Methenolone Acetate intramuscularly every 1 to 2 weeks, or 200 milligrams intramuscularly every 2 to 3 weeks. In weight gain in children aged 15 to 18 years old or over 50 kilograms of body weight, 50 milligrams intramuscularly every 2 weeks. But in youth who have not finished puberty yet, so that's before the age of 15 or 16, after a 4-week treatment, the treatment is halted for 4 to 6 weeks. And I was also able to find the instructions for medical treatments revolving around Methenolone Acetate, better known as Bayer Rehabilitation S, which is, I think, only available in Japan and being used in particular medical settings revolving around the treatment of anemia due to bone marrow failure, in which the dose of Methenolone Acetate is between 1 milligram to 1.5 milligrams orally per 1 pound of body weight. So if you want to do some extrapolation, you get very similar dosages as the oxymetholone dosages, which are prescribed in cases of anemia as well. Unfortunately, I was never able to find the medical insert of Bayer Rehabilitation S in Japanese, stemming from Japan, obviously. So if you happen to live in Japan and you speak Japanese and you can find the Bayer Rehabilitation S medical insert, translate it for me, send it to me by email, and I'll link it down below so that everybody can read what that medical insert contains exactly, right? I would love to read it myself. To summarize these treatments, a starting dose of 200 milligrams Methenolone Acetate intramuscularly, followed by either between 17 milligrams up to 100 milligrams Methenolone Acetate intramuscularly for a maximum treatment duration of 9 weeks in total. And with Methenolone Acetate treatments, if you're a 200-pound bodybuilder somehow suffering from anemia, that dose might be 200 milligrams to 300 milligrams Methenolone Acetate daily. And before you contact your local prescribing physician, don't go out of your way to give yourself stomach ulcers or hemorrhoids or severe nosebleed to go anemic and get this much Methenolone Acetate prescribed. I'm sure at these dosages, there are some deleterious effects, but we'll get into the scientific literature on the human studies shortly. And while we all suffer from bigorexia and weight gain is in order, especially if you're a bodybuilder, a starting dose of 200 milligrams Primobolan per week does sound appealing if you're already following an HRT plus protocol of, let's say, 250 milligrams testosterone Enanthate per week. Then you almost double your weekly intake of anabolic androgenic steroids. But in the medical insert, it says that you need to drop the dosage down to 25 milligrams up to, at maximum, 100 milligrams Primobolan weekly. Now, personally, I don't get out of bed for anything less than 100 milligrams Primobolan per week, and that would only be on a true testosterone replacement therapy base, right? 150 tests and 100 Primo. That's a pretty good HRT plus protocol. But if you're interested in bodybuilding, then I hate to break it to you, you might have to take a little bit more than 200 milligrams Primobolan per week, even if your testosterone dose is pretty freaking high. But before we start looking for scientific evidence as a justification to megadose Primobolan, let's have a look at all of the evidence-based unique characteristics of Methenolone Acetate and Enanthate to see what we're getting ourselves into. And I hate to do this to you guys, and I'm honestly a little bit upset myself. It appears that a lot of the interesting studies performed on Methenolone Acetate or Enanthate are either in German or Japanese language, haven't been translated into English, and in many cases the full publications are not available on PubMed, Science Direct, Google Scholar, or anywhere else. So maybe all those studies that Sharing AG Germany performed on Methenolone Acetate or Acetate, maybe they're somewhere in the vault of Bayer AG Germany after they acquired Sharing AG a couple of years ago. So maybe those publications can be found, but if you happen to work in Bayer and you have a secret multipass allowing you to get into the archives, again, leak those studies somewhere online because I would love to read them. I'm sure I can find somebody who can translate those German studies into English. But for now, if you go down the timeline and you end up in the 60s, 70s, and 80s, a lot of German studies and even a lot of Japanese studies only available as the title, not available as a full publication, and certainly not translated. So I did my fair share of reviewing all the available scientific literature of Methenolone Enanthate and Acetate available in English. As always, full citations down below, evidence-based with citations, unlike most people in the fitness industry who just quote studies but can't seem to remember them, unfortunately. So let's go over the unique characteristics of methenolone. Increases red blood cell production and raises hematocrit in aplastic and refractory anemic patients. Increases white blood cell production during instances of immunodeficiency. That could be HIV positive or AIDS, Felty syndrome, and aplastic anemia. Methenolone Enanthate metabolites offer immunomodulatory activity against reactive oxygen species production in the bloodstream, inhibit tumor necrosis factor alpha production, and offer anti-inflammatory effects. Again, this is from an in vitro study. And methenolone increases bone mineralization and reduces fracture risk in postmenopausal women and patients suffering from osteoporosis. Methenolone increases contractile force and type 1 to type 2 muscle fiber ratio, again stemming from an animal model. It increases mechanic growth factor messenger RNA expression in repetitive stretching. Again, that's an animal model. It's linked down below. It's a very interesting read, but for the sake of respecting everybody's time, we're not going to analyze it. It's still an interesting read, though. Again, follow the citations down below. Methenolone lowers thyroid binding globulin levels, which is the case for many anabolic androgenic steroids, actually. Methenolone acetate metabolites inhibit aromatase enzyme activity in human placental cells, stemming from an in vitro study. The metabolites are on the screen, and these two metabolites actually inhibit the aromatase enzyme in human placental cells to a greater degree compared to exemestane aromacin, which is a suicide inhibitor. This is a very recent study, which we'll go into, and it appears that turmeric rhizomes treated with fertilizer produce methenolone. This is from a plant model. But don't start taking your curcumin C3 complex in an attempt to get Primobolan-like gains. Unfortunately, this over-the-counter supplement has no anabolic potential. If anything, curcumin is known to lower IGF-1 levels somewhat. And if you're not taking actual Primobolan to increase mechanical growth factor to offset the reduction of IGF-1 potentially from a curcumin supplement, then you might be at a net loss. Right? This is a biotransformation of turmeric, adding a fertilizer, resulting somehow, some way in methenolone, which, if to be extracted, could yield some anabolic potential. And on the subject of biotransformation, me and Derek reported that Primobolan offered some aromatase enzyme inhibiting activity about 3 or 4 years ago, if I remember correctly. So I'm happy to see that this is now somewhat confirmed in a scientific study, albeit not entirely. So let's review this study performed by Karim et al., published on February 2024, titled Biotransformation of Methenolone Acetate and Epiandrosterone by Fungi. and evaluation of resulting metabolites for aromatase inhibition. In this study, they used Aromatase tercite mushrooms to biotransform methenolone acetate into 4 metabolites, 2 of which were shown to have aromatase inhibiting effects to a higher degree compared to exemestane. Unfortunately, the full publication isn't available on Science Hub yet, but the abstract gives us enough details to start digging. Again, I asked around. Kurt Havens was very forthcoming to sharing his time, but he wasn't able to find the full publication either. So we have several metabolites that are now known to inhibit the aromatase enzymes in human placental cells. However, I'll also be the first one to say that there's no clear scientific evidence that these newly discovered metabolites, again produced by fungi, are also produced within the human body following a methenolone acetate or methenolone enanthate administration through the intramuscular route, or methenolone acetate when it's taken orally. I reviewed literally all of the scientific literature revolving around doping cases for methenolone acetate and enanthate. And there's apparently 36 theoretical metabolites present for methenolone based on fancy calculations from computer programs. And it appears that I was able to find all of them by name in the literature examining the detection times for various methenolone acetate and methenolone enanthate metabolites for the sake of drug testing in athletes. I'll put them on the screen right now. None of these are able to be named by name because they have very long chemical names. And also keep in mind, please, all these chemical names have synonyms. So even though I went through all of these names to find out if they potentiate some sort of aromatase enzyme inhibiting effect, I was not able to find anything because maybe the scientific literature uses an alternative synonym, if that's even being investigated, the aromatase enzyme inhibition effects of a particular compound, right? If the naming convention doesn't really overlap, then you can't really find this scientific publications, unfortunately. So I did my fair share. I spent a couple days on this, but I could not find any substantial scientific evidence that these 2 metabolites produced by fungi are being produced within the human body, or if the other metabolites that are being produced within the human body have any potential for aromatase inhibiting effect, because it appears that it simply hasn't been investigated yet. So for now, I will still hold firm that Primobolan can lower serum estradiol levels by inhibiting the aromatase enzyme and preventing the conversion of testosterone into estradiol. We're slowly making headway with the scientific evidence, but maybe a decade from now, you guys will say that me and Derek were ahead of our time because it's finally been proven. And on the subject of detection times, I'm not going to leave you guys hanging, don't worry. Let's briefly go over that, because I was able to find in the medical literature what the detection times of methenolone enanthate and acetate actually are. It appears that following a single, again, this is very important to understand, a single administration of 150 milligrams methenolone enanthate intramuscularly, the metabolites are detectable for up to 40 days. And after a 50 milligrams methenolone acetate oral administration, again, 1 administration over the entire duration of the study, the methenolone acetate metabolites are detectable for up to 13 days. And it's the same case for 25 milligrams methenolone acetate orally, and 10 milligrams methenolone acetate orally is only detectable for 5 days, right? Based on the long-lasting metabolites that they were able to investigate. But let's be honest here, nobody out there takes a single administration of 150 milligrams methenolone enanthate or 50 milligrams methenolone acetate. We take these administrations every day for weeks, if not months, maybe even half a year, right? It's not unheard of men injecting 150 milligrams methenolone enanthate, Primo, per day, ending up at 1,000 milligrams Primo per week. So what are the exact detection times based on that? Well, in the scientific literature, we can't find that, but we have reported detection times of methenolone enanthate being up to 5 months, and a reported detection time of methenolone acetate through oral administration of 5 weeks. Now, personally, when I was coaching athletes for drug-tested shows, we would kind of follow these guidelines, right? Assuming that their kidney function was 100% intact, but assuming the detection times are this long at higher dosages that we generally use within the fitness community, and then you might have to switch compounds at a certain period of time, because stopping the Primo 5 months ahead of time for you to test, quote-unquote, natural, you might have to use something else in the meantime because the muscle mass won't be sustained for that long, right? Food for thought. Oh, and before you ask, let me stop this idea dead in its track right here and now. There's absolutely zero reason to make the switch from enanthate to acetate at 5 months before the expected drug test and then drop the acetate 5 weeks before the expected drug test, because oxandrolone will yield much better results than methenolone acetate at a comparable dose, and oxandrolone has a much shorter detection time. So don't even try, don't even bother, please. Okay, let's have a look at the dosages investigated in human studies and the clinical trials to figure out which dosage or dosage ranges are somewhat safe and offer minimal and tolerable side effects. Again, this is discounting all the potential studies which might be available in German or Japanese because I simply can't find the translations anywhere, or they're simply not fully published. And again, I'm begging you guys, if you happen to know anybody that works at Bayer AG Germany that has access to the hidden vault full with human studies performed on Primobolan from back in the day, let me know. I can pay in beer and bratwurst. I'll bring it over in lederhosen if I have to. Dankeschön. Methenolone has been studied in following human conditions and diseases: aplastic or refractory anemia, stroke rehabilitation in hemiplegic patients, that's paralysis on one side of the body, rheumatoid arthritis, inoperable or disseminated breast cancer, postmenopausal women with osteoporosis, liver cirrhosis. And these conditions are stemming from a single study where they assessed the effects of Primobolan regarding liver stress in people suffering from chronic illness, but they don't have any pre-existing issues with their liver. So this was in the context of recovery from cerebrovascular accidents, post-traumatic central nervous system damage, spinal muscular atrophy, Friedreich's ataxia, amyotrophic lateral sclerosis, nephrotic syndrome, gout, and osteoarthritis. So as you might have noticed, based on the unique characteristics and now the human conditions in which methenolone has been investigated, methenolone acetate or enanthate has never, or at least the studies that I was able to find, right, discounting from the German and Japanese studies, it appears that Primobolan has never been investigated in healthy individuals. Only people who are sick with some kind of disease. And obviously people who are sick might experience heightened side effects compared to healthy individuals, even though methenolone acetate or enanthate might ultimately improve their overall quality of life and even keep them alive in particular medical conditions. Now let's go over the aplastic and refractory anemia studies to kind of determine what the dosages were investigated in that context. Again, but to respect your time, we're only going to review the studies which tracked health parameters beyond the expected improvements in complete blood count like hemoglobin, red blood cells, platelets, and white blood cells, because many of the anemia studies just looked if the patients are kept alive to kind of determine if the methenolone treatment was efficacious in that sense. So let's go over these studies briefly. Here's a study which investigated 28 patients with aplastic anemia or other refractory anemia, received 1 milligram to 2 milligrams oral methenolone acetate for 1 to 17 months. In duration, dosages investigated ranged from 50 milligrams to 200 milligrams daily, or 100 milligrams methenolone enanthate intramuscularly 2 times monthly for up to 20 months. 12 patients, 43% observed normal complete blood count parameters during the treatments, and 4 other patients saw an improvement of their anemic state. Observed side effects during methenolone treatment were cholestatic jaundice, liver function returned to normal after treatment was discontinued. Again, what you expect on 200 milligrams methenolone acetate per day, right? Cholestatic jaundice might occur, but the beneficial effects regarding complete blood counts also disappeared in 1 patient. The other side effects were virilization, hoarsening of the voice, menstrual disturbances, and acne in the female patients. Although these side effects were not severe enough to discontinue treatment. So now we already have an answer for my female audience, like the 1 to 2% that actually watches this channel. Don't take 50 to 200 milligrams methenolone acetate per day because it can cause issues with your liver and virilizing side effects. And that is kind of confirmed in this following study. This study shows that the patients suffering from aplastic anemia, the female patients experienced virilization, and some patients experienced severe muscle cramps during treatments. The issues disappeared by lowering the dose from 3 milligrams per kilogram of body weight daily to 1 to 2 milligrams per kilogram of body weight daily. So lowering the dose might reduce the virilizing side effects, but if you're a 50 kilogram girl and you're taking the 1 milligram to 2 milligram per kilogram of body weight dose, that's still 50 milligrams methenolone acetate, which I think is still way too high. And that's again further confirmed in this study, where they investigated the effects of 50 to 300 milligrams methenolone acetate orally daily, often for months to years in duration. Treatment duration was dependent on the furthering of lifespan. All but one patient eventually died from anemia-related complications. During treatment, female patients commonly reported virilization, and signs of liver toxicity was reported in 21% of the patients. So now already 3 studies showed that virilization occurs with methenolone acetate, and liver toxicity occurs at this dose of 50 milligrams or higher. Why are the women out there taking 50 milligrams methenolone acetate? What? Stop doing that, please. That's only 3 studies and we have many more to go. So to kind of answer the question if methenolone acetate up to 25 milligrams per day is safe for females, there's no scientific evidence because I don't think that it has been investigated at that low of a dosage. From what I was able to piece together, it's 50 milligrams upwards, often 100 milligrams, 200 milligrams, even 300 milligrams daily. So we can't really pull from the scientific evidence. What I can tell you from anecdotal experience, having coached many women, which I would always favor to use oxandrolone instead of methenolone acetate, is that the ones that came to me running methenolone acetate at 25 milligrams daily all had virilization. So I would recommend all women out there not to touch methenolone acetate and use oxandrolone instead, which has been extensively studied, and I already made a deep dive about it. I'll link it at the end of this one. Okay, let's move over to the stroke rehabilitation in hemiplegic patients study. Again, that's paralysis on one side of the body. 15 hemiplegic stroke elderly patients during subacute rehabilitation received 100 milligrams methenolone Enanthate weekly for 6 weeks in duration. The observed negative effects were increased fasting blood glucose levels, hyperproteinemia, increased cholinesterase levels, and mild liver dysfunction. None of these events were serious enough to stop the treatment. Methenolone Acetate increased cross-sectional area of the thigh muscle between 13.4% to 14.5% on the affected side. This is a site where they were, of course, using rehabilitation to increase motor function and overall muscle size. But this is on the side where they experienced paralysis after 6 weeks of rehabilitation. So even if your motor function and your skeletal muscle function is not that great, 100 milligrams methenolone Acetate weekly for 6 weeks in duration can actually increase a thigh muscle size. So this comes very, very close to what we would do in the fitness industry. Obviously, we are not paralyzed on one side of the body. So luckily, we can train hard and maximize that methenolone Acetate. And in this study where they investigated the effects of methenolone regarding liver toxicity in patients with chronic illnesses, they took 23 adult patients with chronic illness, excluding liver disease. They received either 100 milligrams methenolone Acetate intramuscularly weekly or 25 milligrams methenolone acetate intramuscularly 3 times weekly, post-injection pain in a bottle, I will tell you that, or 20 milligrams methenolone acetate orally 3 times weekly for 6 weeks in duration. So this dosage of methenolone acetate is far lower than the dosages investigated in the aplastic or refractory anemia studies. And even though that might sound promising, because the researchers noted that administration of twice the usual therapeutic methenolone dose, again, it might be much higher methenolone acetate for aplastic anemia, but whatever, did not significantly alter blood work parameters, particularly kidney or liver markers. So they did not investigate if any virilization occurred. And if you scroll down in this study, you can see that it's partially funded by Sharing, Squip, and Organon. So take it all with a grain of salt. They have financial incentive to not have any terrible negative effects of these medications investigated because they produce these medications. So honestly, regarding safety and efficacy, there's not much we can work with now because all of these patients are somewhat unhealthy. And they haven't really investigated the dosages that we're after or investigated the blood work parameters and the side effects that we would like to know about. So let's have a look at the high-dose Primobolan studies performed in inoperable or disseminated breast cancer patients. We'll start with this one from 1975, performed by Nutter et al., titled Treatment of Disseminated Carcinoma of the Breast by Methenolone Acetate. 43 postmenopausal female patients with inoperable or disseminated breast cancer were treated with a specially manufactured 200 milligrams per 1 milliliter Sharing Primobolan Depot. This is well before Shearing AG was acquired by Bayer AG, and Primobolan was rebranded as Rimobolan. So there is some scientific evidence for a 200 milligram per 1 milligram Methenolone Enanthate, albeit that the post-injection pain, the reported post-injection pain, might be quite severe. Not mentioned anywhere in this publication, so maybe Shearing was able to do it, but all the underground labs are not. All right, let's have a look at the results. At 3 times 400 milligrams per 2 milliliter, Primobolan Depot intramuscularly per week. So that's 1200 milligrams Methenolone Acetate per week total. That's a pretty hefty dose. For up to 3 months in duration, increased virilization occurred. Again, this is all female patients. Dosages were lowered to 2 times 200 milligrams per 1 milliliter intramuscularly Primobolan Depot per week, as clinical anti-cancer effects were already observed at this dose. So it's a dose reduction from 1200 milligrams per week down to 400 milligrams per week. Depending on the rate of cancer remission, treatments lasted up to 15 months in duration. Just keep in mind that not all patients were responsive to this treatment and observed a breast cancer remission or stagnation for that matter. Liver and brain metastases did not respond to Primobolan treatment. During the high-dose Primobolan treatment, patients experienced virilization and increased libido, so that might be a beneficial effect. Leg cramps occurred in about 50% of the patients, similarly to the aplastic anemia patients with a very high-dose Methenolone Acetate administration. These symptoms disappeared after a dose reduction or after discontinuation of the treatment. Increased red blood cell production was observed, but there were no changes in liver function during the treatment at higher dosages of Methenolone Acetate. So if we take this data from the single study, and there's more coming, don't worry. If we take the data from the single study and extrapolate that to healthy men who are into health and fitness and bodybuilding or some sort of strength sports where Primobolan is desired, then experienced virilization is obviously an afterthought because we're men. Increased libido, yes please. Leg cramps, we can easily mitigate with taurine and a normal electrolyte intake. And increased red blood cell production, that's usually also something we can manage with, doing therapeutic blood donations or taking IP6 to inhibit iron absorption or managing our sleep apnea with a sleep study and a CPAP machine, right? All these things I would say we could easily manage. And if there's no change in liver function with injectable Methenolone Enanthate, then why would you even consider Methenolone Acetate as an oral therapy for anabolism? Now, unfortunately, this study did not investigate changes in serum lipid levels, total cholesterol, LDL, HDL. That was not investigated. Sex hormone levels, neurosteroid levels, that was not investigated regarding if there's a suppressive effect on luteinizing hormone, follicle-stimulating hormone, and if total testosterone, estrogens, DHA sulfate all come down, which I'm sure we can safely say that those levels would come down with this much Methenolone Enanthate. And lipid levels might already be skewed in postmenopausal women because they're basically estrogen deficient. All right, moving over to the next high-dose Primobolan study performed by Kennedy et al., published in 1968, titled Effects of Methenolone Enanthate in Advanced Cancer of the Breast. In this study, they investigated the same dosages of 400 milligrams Methenolone Enanthate injected intramuscularly 3 times weekly, a total dose of 1200 milligrams over the week. And the reported side effects were edema, anorexia, acne, virilization, increased libido, flushing, and irritation at the injection sites, probably because they use castor oil. And if you inject 6 milliliter castor oil in virgin muscle, then some post-injection pain is to be expected, and not everybody responds favorably to castor oil. So those are all observed side effects, not tangible side effects with MRIs or blood work analysis. Again, unfortunately, and this is the last high-dose human study in existence, basically, from 1981. So that means that all the high-dose Primobolan studies have been performed before I was born. This is all we have to work with, guys. All right, performed by Garbrecht et al., published on March 27th, 1981, titled Hyperlipoproteinemia during additional Methenolone administration in the treatment of metastasizing carcinoma of the breast. This was a German study, which was translated by Alex. Much appreciated. So basically, to summarize this study, 28 postmenopausal women, patients with an average age of 55 years old, suffering from metastasizing breast cancer, received 400 milligrams Methenolone Acetate intramuscularly 3 times weekly, a total dose of 1200 milligrams weekly. After 50% of the patients with breast cancer went into remission, so that's, at least that sounds good, the dose was lowered to either 200 milligrams to 300 milligrams intramuscularly 3 times per week. So that's a total dose of either 600 milligrams or 900 milligrams weekly for the remainder of the treatment. The average treatment duration was about 7.7 months. After several weeks of 600 milligrams to 1200 milligrams Methenolone Acetate weekly, serum total cholesterol levels increased from 240 milligrams per deciliter on average to 262 milligrams per deciliter on average, with the highest recorded level ending up at 526 milligrams per deciliter. So these postmenopausal women already had terrible lipid levels with a total cholesterol at the baseline of 120% of what is considered to be healthy, ending up at 130%. So that's an increase of, let's say, 20% after a Methenolone Acetate treatment up to 1200 milligrams weekly. I would not say that that's a terrible result, even though the highest recorded level was, 526 milligrams per deciliter, which is certainly a very high total cholesterol levels. But the researchers also noted that there was no clear correlation between the Primobolan dose and serum total cholesterol levels. After Primobolan was discontinued, it appears that total cholesterol levels returned to baseline. And to summarize all of these studies, the low-dose Methenolone Enanthate studies and the high-dose Methenolone Acetate and high-dose Methenolone Enanthate studies, all things considering, I would say that amongst all patients, Primobolan up to 1200 milligrams weekly is well tolerated from a cosmetic and side effect profile perspective. Even though blood work parameters might change, right? We do know that total cholesterol levels increase, red blood cell production and count increases. You might experience virilization if you're a woman. Libido might go up, acne might manifest, hypercalcemia might set in, potentially leg cramps or irritation at the injection site, right? This is all stemming from the scientific literature. But if you consider yourself a man and you're healthy and you use ancillaries to mitigate some of the investigated side effects, the documented side effects, then I think high-dose Primobolan is reasonably safe because we know how to control total cholesterol levels. We know how to control red blood cell count. And we also know how to keep our liver healthy with various ancillaries, over-the-counter supplements, and dietary practices. And of course, not megadosing Methenolone Acetate up to 300 milligrams daily, that's probably also a good practice to incorporate. And it appears based on scientific literature that Methenolone Acetate through the injectable routes is liver safe. So if all of these side effects are worth it to you, then feel free to proceed into your next Methenolone Acetate or acetate cycle. I'm sure you already have the answer ready for you. It looks like it's worth it to me. Now, I'll also be the first one to say that Primobolan has not been investigated regarding kidney health or cardiac health or brain health, right? We don't know if Methenolone is kidney toxic, cardiac toxic, or neurotoxic because those studies have never been performed. So if you hear somebody out there say that you should run Primobolan because it's not kidney toxic, they're full of because it hasn't been investigated, or at least not to my knowledge, discounting for the studies performed in German or Japanese. And if people have access to the studies, let's publish it for the sake of the community so we can all learn. From the research that I've done, there's no clear scientific evidence that Primobolan is either kidney safe, cardiac safe, or brain safe, right? So please don't make these assumptions that instead of compound XYZ, we should all run Primobolan. If you want to run Primobolan, go through the scientific literature that's available and then base your decisions on the published and available results. So based on the scientific evidence, I would say that 100 milligrams Methenolone Acetate intramuscularly per week is somewhat safe, but the next increment of investigated dosages is 400 milligrams, 600 milligrams, 900 milligrams, or 1200 milligrams weekly. And in the dosages, side effects do start to occur. Now again, we can use ancillaries to mitigate these side effects, but it's entirely up to you, your responsibility, that if you do ramp up the dose to 400 or 1200 milligrams Primobolan or anything in between, to do your blood work, right? Check your red blood cell count, check your total cholesterol levels, check your liver markers, check your kidney markers, do everything you need to do to ensure that your health, a Primobolan user, is sustained. I mean, I think if you're a healthy male and you do everything right, based on my own personal blood work results of dosages up to 1,000 milligrams of Primobolan per week, I would say that you can manage your blood work parameters perfectly if you deploy your ancillaries and over-the-counter supplements correctly at the right times, right? Of course, you're not going to start at 1,200 milligrams Primo right from the beginning of your cycle. Hopefully, you slowly but surely build your dosages up based on response and what your goals are. I would say that it's reasonably safe and manageable, but you do have to deploy the ancillaries to make that work. And after all of this research and all of the experience that I have with Primobolan myself and interpreting blood work results of all of my clients who use Primobolan over the years, I would say that Primobolan should be your first choice as a secondary injectable on top of your testosterone base, especially if you consider ramping up the dosages to multiple grams per week, right? I feel that Primobolan is the safest injectable compound, although the scientific evidence is lacking, right? Not so much scientific evidence has been performed on Methenolone Enanthate or acetate when you compare that to Nandrolone or Oxandrolone or Oxymetholone for that matter. I'll put my dosage recommendations on the screen. For men, I would say that the sustainable and tolerable dose of Methenolone Enanthate is 100 milligrams to 300 milligrams intramuscularly or subcutaneous weekly. So that's either breaking up the dose to daily or 3 times per week administrations until blood work parameters become unmanageable. But I think at 300 milligrams Primobolan plus, let's say, 300 milligrams test per week, you might be able to run that for a couple years in duration. And the deleterious dose might be anywhere between 400 milligrams to 1,200 milligrams for a maximum of 26 weeks. When I say deleterious, that's a little bit of an overstatement. Again, the scientific evidence regarding safety and efficacy and overall healthiness is lacking. And I would say 26 weeks is doable, even at the high dose, based on the personal blood work that I've seen for myself and all of the people that I worked with over the years. But if your blood work parameters become unmanageable before the 26-week mark at 400 milligrams per week, you're not deploying the ancillaries correctly, or Primobolan is simply not meant for you. Regarding the women, I would say that the sustainable and tolerable dose of Methenolone Enanthate is 0 milligrams weekly. I know this sucks to hear, but I don't think that Methenolone Enanthate or acetate is suitable for women at all. So if you want to go with the deleterious dose of Methenolone Enanthate, I would say 10 milligrams to 70 milligrams sub-Q weekly, either 1.5 milligrams to 10 milligrams sub-Q daily, or 3.3 to 23.3 milligrams sub-Q 3 times weekly for a maximum of 6 weeks. This is a very short period of time, and the reason why I'm saying 6 weeks in duration is because that it appears that all the cosmetic changes at a very low body fat percentage, let's say 8 to 10% body fat, again, depending on the competitive class, that's already observed within 6 weeks. So why run it longer if you're experiencing virilization at the 6-week mark already? You're not going to look any better beyond the 6-week mark, but you're going to get increased virilization. So only run it for the period of time that you get the maximum cosmetic effects, but the lowest virilizing effects. And rest assured that even at the 6-week mark, Methenolone Enanthate will virilize you even at 10 milligrams per week, right? It's purely based on observation. Now, regarding Methenolone Acetate, I don't see a reason to run it because it's inferior to Oxandrolone. And if you can source Methenolone Acetate, which might be even more expensive on a milligram for milligram basis, you get less milligrams for Methenolone Acetate compared to Oxandrolone because it has an ester attached. I think that the bioavailability is also lower. Methenolone Acetate yields 78.8% net methenolone and 12.2% acetate, so that means every 25 milligram tablet will only give you 22 milligrams net methenolone. But I would feel that 20 milligrams oxandrolone gives you better results, might be cheaper even, than 25 milligrams methenolone acetate. So, you know, if you want to go with Primobolan, just inject it. Run your oxandrolone, your Anavar alongside of that. I think test Primo Anavar is a killer combination, assuming you're a man, not a woman, you're going to be virilized. So I don't see a reason to run Methenolone Acetate. And again, to emphasize for all the ladies out there, the scientific evidence regarding Methenolone Acetate at lower dosages is very, very thin, right? At higher dosages, it's been known to cause virilization. I've seen women experience virilization at 25 milligrams per day. And since oxandrolone has been extensively studied, and it appears that, at least anecdotally, that a low dose or moderate dose of oxandrolone for months in duration doesn't cause any virilization, and if it does, it's somewhat manageable or reversible after discontinuing the oxandrolone. So just because your coach says that methylone acetate it's safe up to 25 milligrams per day, doesn't mean that it is. It doesn't mean that it is. So please look into oxandrolone instead. I don't see a reason why men or women would want to run methylone acetate at all. All right, let's wrap it up here. You can do your blood work over at Merrick Health if you live in the United States. Keep in mind that Primobolan, Rehabilitation, is only available in the Turkish and maybe the Spain pharmacies. It's not FDA approved within the United States. So if you run Primobolan and you're worried about your blood work increasing red blood cell count, total cholesterol levels, and you want to keep track of your kidney markers and your liver markers, you can still do your blood work over at Merrick Health. But it doesn't mean that the healthcare providers are going to agree with what you're doing. At least you can preemptively manage your blood work results if you have the results ahead of you. And otherwise, you can do your blood work here in Thailand at Bria Labs or a blood work anywhere else that you live, right? It's very important for you to do your blood work. Don't procrastinate. Get the data, make the adjustments, and stay healthy if you want to run Primobolan or any other kind of performance-enhancing drugs. Follow me on Instagram and TikTok at Vigorous. Vigorous Crew, you guys know what to do. A front double bicep for you guys. Imagine how this is going to look with a little bit of Primobolan in the picture. Not sure when, but at one point or another, I'm sure I'll add some Primobolan back in. Thank you guys so much for watching, and I'll see you in the next video.